Hello, hi everyone. So, this is the second part of the lecture Principles of Tooth Preparation. These are the learning outcome. That was the first is to determine what are the advantages of using a supragingival margin. The second outcome is to discuss the indications for using subgingival margins, in which situations we can and should use subgingival margins so that we may know when not to use subgingival margins. And the third outcome is to discuss the various methods that are available to preserve the tooth from being over prepared and to protect the surrounding gingival tissues, the interdental papilla, the cheek, and the tongue. Okay, so let us go through quickly again the various types of finish lines that are available for fixed partial denture or crowns. Okay, so first is the chamfer. We already discussed that chamfer is a margin which has a rounded internal line angle at the axial wall and at the actual margin. So this is most commonly used when you are giving a porcelain fused to metal restorations, even for nowadays for the all ceramic restorations like zirconia restorations, Emax, we can use chamfer or a heavy chamfer type of restoration as mentioned over here. The third is the shoulder that we discussed, that the shoulder is the most preferred restoration for the porcelain fused to metal and for all ceramic restorations in the past, but nowadays due to advent of technology and better performing materials, we can use a heavy chamfer instead of shoulder, but nevertheless shoulder is one of the most common finish line configurations. Then we have the radial shoulder one type. It's also a type of shoulder, but with an obtuse angle more than 90 degree. A shoulder has a 90-degree axial gingival line angle, whereas a radial shoulder has a more obtuse angle. Okay, and then we have the shoulder with bevel. Then we have the knife edge and feather edge, which are most commonly we use for PFM restoration, partial coverage restoration, and crowns. Okay. So the preferred gingival finish line for fill veneer metal restorations is a chamfer. Okay, this finish line exhibits the least stress in the underlying cement, and it can be prepared by a torpedo or a rounded and tapered diamond burr. Okay, so conservative. It is more conservative when compared to a shoulder finish line, obviously. And when we use a heavy chamfer, it is the same as using a shoulder, that is it removes the same amount of tooth structure, whereas a chamfer is more conservative than a shoulder. To prevent this chipping and fracture, we also have a different specific material called as a shoulder porcelain. So this is the normal type of feldspathic porcelain only, but with a greater concentration of uh, ceramic particles, resulting in greater strength at the margins. Okay, and now coming to the margin placement. So when we consider supragingival margins, so what are the possible advantages of a supragingival margin over a subgingival margins? Okay, so that we may choose wisely when to use a supragingival and when to use a subgingival margin. So first thing first is, whenever possible, always try to keep your margins supragingival. Okay. Now, having said this statement, this is not always possible because of the patient's high aesthetic demands, because of the restoration being in an aesthetic area such as the maxillary anterior teeth, maxillary incisors, canines, and uh, even up to the maxillary premolars, and the patient has a wide smile, okay, or the high lip line. So in that case, it is not possible to keep a restoration margin supragingival. Nevertheless, whenever possible, the restoration margins should be kept supragingival because it is more cleansable, more hygienic, more easier to remove the cement at the time of cementation. Okay, supragingival margins are also easy to prepare because we can actually visually see where our margin is being placed. It is less traumatic to the gingival tissues around the abutment teeth. They are usually situated on the hard enamel and not at the CEJ or in the cementum, as the case with many times with the subgingival margins when the recession has taken place. The other advantages of having a supragingival margins include the following: they can easily be finished without any soft tissue trauma. Okay, so since they are supragingival, the burr or a diamond point is not touching the free gingival margin or is not removing the internal epithelial lining of or the junction epithelium from the sulcus, so there is less bleeding. Capturing impressions is also more easy since these margins are supragingival. It is easy for the patient to keep them clean and hygienic and plaque free. Also, impressions are more easily made because you do not need to use any type of gingival retraction procedure, or and there is no bleeding, no gingival cranicular fluid because the margin is supragingival. So it's much easier for a newbie to capture the impression accurately. Then the restoration can be easily evaluated at the time of the placement for the proper marginal adaptation, because everything is supragingival. Easily it can easily assessed, as opposed to a subgingival margin which is inside the sulcus. So in that case, a supragingival margin is more advantageous, because of basically it's an easy margin to prepare and to reproduce and to take impressions and to verify. Okay, that is, those are the advantages. Now coming to a subgingival margin. So in what cases do we use a subgingival margin? Okay. So if the dental caries cervical erosion extends subgingivally, that is, the patient has a cervical abrasion, abfraction, or class 5 type of cavity that extends subgingivally, uh, then in those cases it is becomes necessary to involve that area in the preparation so that it can be covered by a full coverage crown or a veneer. Okay, so as not to have later secondary caries and micro leakage in that area. Okay, the second thing is when the proximal contact areas extend to the gingival crest, when the adjacent tooth have broad contact area and they extend all the way down to the interdental papilla area. In such cases, in order to break the contact, we have to keep lowering the margin until the proximal contact between the tooth that is being prepared and the adjacent teeth is broken. Okay, so in such cases also we have to extend the margins proximally subgingivally when additional retention resistance is needed. So most oftenly you will see that sometimes in mandibular premolars and maxillary second molars the crown height is very short. Okay, so in such cases, in order to have a sufficient vertical height of the restoration, we need to extend the margin subgingivally so that we can gain additional 1 to 2 of the vertical height, which is important for the retention of the retainer of the crown on the abutment teeth. That is one of the greatest advantages. When the margin of the metal ceramic crown is to be hidden subgingivally, you see, when you are using a PFM crown, however good a PFM restoration has been fabricated, there is always a slight gray hue or gray shadow that emits through in the cervical area of the restoration because of the underlying metal substructure. In order to minimize this grayish hue or the grayish shadow reflecting from the gingival margins, if we lower the margin subgingivally by 1 to 2 that is within to the sulcus depth, then in such cases, to a large extent, the gingival shadow is minimized. So that is one advantage. Then root sensitivity. Sometimes patients have root sensitivity, okay, because of the slight recession in the cervical areas, okay, due to gingivitis or due to localized periodontitis. And if patient has a good hygiene and the periodontitis has been taken care of, has been arrested, in such cases by covering the root surface we can minimize the root sensitivity in such patient, especially when who have cervical abrasions. Okay, then we have the modification of the axial contours is indicated, such as to provide an undercut for retention for a clasp, or sometimes these PFM crowns and PFM bridges, the retainers or the premium bridges are also act like the retentive tooth for a cast partial denture, for acrylic partial denture, which and the clasp needs to be designed and put on these teeth. So since the the tip of the clasp goes in the cervical undercut, so in order to uh, engage or cover protect this area, the crown margins have to be extended subgingivally so that the clasp does not end at the margin which is supragingival. Okay, so these were the indications for a subgingival margins and also the advantages that these offer. Okay. So these are the various advantages and disadvantages of various type of finish lines: feather edge, chisel edge, bevel. So the most common thing with this feather edge, chisel edge, and bevel edge margins is they are all very conservative of the tooth structure, require minimal axial reduction of the tooth, and but they are mainly indicated for a full veneer metal crown or a partial coverage, a proximal half, or the 3/4 crown, or the 7/8 crown, or the reverse 3/4. These type of metal retainers, these are used, or when we are giving a metal collar for a PFM restoration. Okay, so these are the disadvantages are they are non-aesthetic, they do not provide adequate bulk of the material, and they are difficult to capture in the impression, and they are difficult to for the technician to ascertain where the finish line is ending, because they are such fine finish lines. Whereas we have huge advantages when we consider a chamfer or a heavy chamfer or a slope shoulder or radial shoulder type of preparation. But the disadvantages of these restorations, that is the shoulder and the radial shoulder, they are more destructive to the tooth, they are less conservative, they require more removal of the tooth structure axially from the cervical areas. Okay, so those are the disadvantages of these material, but these are the most preferred finish line for all of your all ceramic and your uh, full veneer porcelain infused to metal restorations. Okay, so the other things you can go over here in this table. Okay, so we can see over here these are all the different type of finish line. This is the SCM pictograph displaying all the different type of finish lines. Over here the picture, in this picture over here we can see this is a feather edge finish line. You can hardly determine where the finish line is ending, where the natural tooth is starting. Okay, and then we have this is a bevel type of restoration. Again, you can make out where the finish line is, but it does not provide sufficient bulk of the tooth structure in this. That is why these restoration finish lines are most probably for full veneer metal cast restorations. Whereas over here we can see this is a chamfer type of restoration, which provides a distinct finish line and provides more bulk of the material. And this is more of a shoulder, which has a more of a right degree or 90-degree angle between the axial tooth surface and the gingival finish line. This is a radial shoulder. As you can see, this is more obtuse or a sloped shoulder, providing more bulk of the material and can be finished subgingivally to in order to be more aesthetic. This is a shoulder with bevel. You can see this is the shoulder and this is the bevel on the outer side. Again, this is used for full veneer PFM restorations, in which we plan to give a metal collar or a metal edge which can be tucked in subgingivally. So now coming to the different methods to protect or prevent the over reduction of the tooth structure during the tooth preparation. Okay, so we have for these we have the depth grooves, the depth orientation grooves, the functional cusp bevel FCBs, and preparing the teeth with by overlaying them with a mock-up material. So in cases of smile designing, excessive tooth wear cases. Okay, so how do we prep the tooth sufficiently without causing over reduction and causing pulpal trauma? That is by using depth grooves incisally or occlusally, and by using depth orientation grooves on the axial walls of the tooth, especially when it comes to the anterior teeth where we have to do a two plane reduction, and by using again depth grooves on the posterior teeth for the axial reduction. Okay, and by giving a functional cusp bevel on the posterior teeth, that is the mandibular bicuspids and the molars, and similarly maxillary bicuspids and the molars. So a functional cusp bevel is given on the buccal cusp, that is the centric cusp or the primary holding cusp of the mandibular posterior teeth, and a functional cusp bevel is given on the palatal cusp in case of the maxillary posterior bicuspids and molars. Okay, next is in cases of excessive tooth wear or tooth surface loss, in order to not to aggressively or over reduce the tooth structure, we can do first a mock-up, prepare a mock-up from the laboratory of how the restoration, finished restoration should look like. Then using putty indexes made over the mock-up, we can first do a acrylic or any material of your choice for, and take the impressions. So in this way we are making sure that we do not excessively reduce the teeth which have already gone excessive tooth wear. Okay, and then these are the final restorations over here. In this case, patient had was given veneers for the anterior teeth from canine to canine, and onlays and crowns for the posterior bicuspids and the molars, as you can see over here. So this is a tooth loss or tooth surface loss case. Extensive restoration of full arches. In such cases, we can use a mock-up followed by preparation. Okay. Now coming to the protection of the surrounding gingival tissues when preparing the abutment teeth. Okay, so for this we can use metric bands. Okay, we can use wedges, we can use a gingival protector, we can use rubber dams, retraction cords, various mechanical forms of protection. Okay, so this is a gingival protector. Basically it has similar, it has a handle similar to a mouth mirror with a ball socket at the end, and a shield, something like your matrix band at the tip of the shield. Okay, so this shield will protect the tooth while preparation of for the subgingival margins or equigingival margins, so that we do not strip or damage the gingival margins. Okay, we can do preparation without this also, but many people are very aggressive and can result in a lot of gingival trauma, resulting in bleeding, blood clot formation, and recession of the gingiva. So in such cases, you can use this hands when doing reduction proximally to, in order to avoid injury to the adjacent teeth and to provide injury to the interdental papilla. We can use matrix bands or mylar strips, or even we can use keep a protective instrument like a chisel in interproximity to prevent damaging the adjacent teeth. Okay, and then we can also use rubber dams for tooth preparation, but it is not very easy. Some people have used it, but it is generally not recommended. But in cases for anterior teeth, for a veneer, for a few crowns, we can use rubber dams. A thick type of heavy duty rubber dam can be used. The regular rubber dam used in operative dentistry or conservative dentistry will not do, because it will tear very easily. The disadvantage is you cannot use it for a full mouth preparation cases. You cannot use a rubber dam while taking impressions, because it is very difficult. The impression trace cannot be inserted with the rubber dam clamp, and the rubber dam being in the mouth. Also, evacuation of the fluid has to be done frequently because of the rubber dam, and visibility is poor. And then also the another problem is that some, since the rubber dam is made up of latex, or it contains some chemical medicaments like thiopental, that can retard the impression material at when it comes in contact with it, and resulting in a distorted impression. Okay, just like latex gloves are not recommended while mixing the rubber based impression materials, because they can retard the setting of the impression material, light body and putty in that area. So, but yes, in some cases we can use rubber dam, generally not recommended. These are the special clamps, Ferrier 212 and Brinkler B5, that are used for tooth preparation. Then we have retraction cords. So the retraction cords come under the mechanical forms of gingival retraction in order to protect the gingival tissues and in order to open the gingival sulcus so as to capture a accurate impression. Okay, so we have, apart from rubber dam, we have a lot of other materials like copper bands, aluminum tubes, leather bands, rubber rings, cotton twills. Okay, so uh, for retracting gingival tissues. Okay, we'll be studying more in detail about the rubber dams in the semester 2, where you have an actual chapter or a topic, lecture topic on impression making and soft tissue retraction. Okay, soft tissue management in fixed prosthodontics. But suffice to say, a rubber dam is the most popular material used for gingival retraction. There are three types of rubber dam based on the configuration: knitted rubber dam, retraction cords. Based on the configuration, they are knitted retraction cords, twisted retraction cords, and the braided retraction cord. These may be plain, or these may be impregnated with a chemical medicament, usually an anticoagulant and an or an astringent, that is a hemostatic agent, to prevent or stop the bleeding in the gingival sulcus when we are capturing the impression for a subgingival margin. They are available in various sizes from triple O to 3. Some common examples are the Ultra Pack, which is one of the most popular brands in retraction cords. We have Record, we have Sultan retraction cords. There are many type of retraction cord. You can see the sizes extend from triple O to 3. Okay, most common sizes. We rarely use the number 3 and number 2. Most oftenly we use the double O to number 1 retraction cords. Okay, so this is a retraction cord. You can see over here, this is a knitted type of retraction cord based on how it is made. You can see over here they are color coded based on the sizes, and these are pushed into the gingival sulcus following the preparation, or when we want to lower the finish line from supragingival to subgingivally. Okay, in that case, once the preparation has been finished supragingivally, the retraction cord is placed, usually a triple O or double O size retraction cord, and then the finish line is extended subgingivally. Okay, and this is an instrument that is known as a Fisher's cord packer, which is similar to your what you call your Carey's excavator instrument, but it has a small serrated edges at the tip that allows it to engage and push the retraction cords into the sulcus. Okay, many manufacturers make retraction cord packers. There are single cord packers, there are double cord packers. Okay, and then these are the various medicaments that can be used for impregnating the retraction cords. Okay, we can either use the retraction cord plainly without any chemical medicament or a hemostatic agent, or we can use all of these various chemical medicaments and hemostatic agents. The most commonly vasoconstrictors are the epinephrine and norepinephrine, and the various other anticoagulants and astringents most commonly used are the ferric sulfate, aluminum chloride, aluminum sulfate. Then we have caustic agents such as tannic acids and silver nitrate and zinc chloride, which are not used much because they cause the precipitation of the proteins from the gingival sulcus, cause the shrinkage of the gingival sulcus. They can also cause uh, temporary necrosis of the gingival sulcus resulting in recession. So these are not much used. Most popular ones are the ferric sulfate, aluminum chloride, and aluminum sulfate. Okay, epinephrine is a fantastic vasoconstrictor and hemostatic agent, the most potent among all. But because epinephrine is a vasoconstrictor in patients with known cardiac disease or history of cardiac episode, it is to be used with caution, because once it enters the bloodstream, it can cause tachycardia, rise in blood pressure, and such things. It can result in a mild cardiac episode, so which is not desirable. So that's why epinephrine not used much. It is usually used in the concentration of 6 to 8%, known as the racemic epinephrine. Okay, so we also have some other medicaments which are not listed here, which are known as oxymetazoline and hydrazolene, which are also fantastic neovasoconstrictors. Anyway, these we'll be talking about more detail in the chapter on impression making and soft tissue management when we move along further. Okay, so that brings us to the end of this lecture.